We're live.
Hello, everybody. Welcome to MHTV. We've got the full team here and a special guest, so welcome. And then we're also going to be doing something slightly different. We're going to be talking through somebody's learning and actually exploring that. So we'd really love it if you could join in with us. And to show you how to do that, let's go to Vanessa so she can tell you. Hi, Vanessa.
Hi everyone. So for those of you who've not joined us before, you can join in two ways, either on Facebook. So if you go over to the Unite MHNA Facebook page, like the page, you should see the live stream pop up there. There's opportunity for you to ask questions. We love a bit of interaction, so do ask any question or share any thoughts, and I'll keep an eye on those and feed them in tonight. If you're on Twitter, now known as X, you can also join in there by following the MHTV hashtag. You should see the live tweeting on there. Please ask any questions, add comments. We like it to be interactive as always. Thank you.
Okay, but let's go to Linda now. Linda, can you tell us a little bit about yourself? You're our special guest tonight. Hello.
Thank you. Hi. So I'm Linda, obviously. Now I'm a mental health nurse. I qualified in 1994 and I've worked in various jobs, inpatient, outpatient. I've been working in Nottinghamshire in the community since 2018, and I've literally just finished doing my Advanced Clinical Practitioner training. Got final sign off today. So yeah, it's been quite a journey, which has brought me to the point that we're going to be talking about today.
Absolutely. Congratulations. That's
Congratulations.
Yeah, it's been quite a slog, but worth it.
Well, let's talk about the kind of the subject. Let's introduce that. Perhaps you put your first slide up so that we can see what it is you've been focusing on and why it's so important for mental health nurses to know about.
Okay, so as I went through we'll call it ACP training for short, so I will share my first slide. There we go. Let's have a look. I don't think I'm doing the... Can you see that now? Have I managed to get
we
that?
can.
Okay.
Absolutely.
So anyone watching will have to excuse the formatting errors because I've had to go from a PC to a Mac very quickly because my mic wasn't working. So as you can see here, these things always happen, don't they? So going through my ACP training, they do bring in a lot about physical health, which was a very steep learning curve for me because I'm mental health all the way and very much into therapy and all those kind of things that we're used to, I think, as mental health nurses. So this side of things was incredibly interesting and, really revealing about how if we can actually address people's physical health needs at the same time, we're going to be improving their mental health, and it's really important. And the bottom line is that our patient group, they died 20 years earlier than the rest of the general population, and that was discovered many years ago and is still happening today. So so I stopped that share of that slide then.
So just go on to the next one.
We just go on to the next one. Okay, so
absolutely.
We'll get on with it. So I've just mentioned then, so why do we need to talk about this? So what is serious mental illness? So a lot of people will know that, but for those that don't, so we class it as psychological problems that are often so debilitating a person's ability to engage in functional occupational activities is severely impaired. Traditionally, it used to be schizophrenia and bipolar, but I think this covers anybody that fits that category. Things have changed, haven't they? And it is well known, and there's so much research and evidence to show that people with poor mental health are increased risk of physical ill health. There's many factors. This is all research based, so lifestyle choices, poverty, ineffective prevention, poor access to effective care, poor commission of services, stigma, iatrogenic risk factors. Well, they're the things that we do to people, so like medication, things like that, so we can cause some of these problems with our treatment. Ethnicity. So back in 2012, Rethink Mental Illness published their 20 Years Too Soon report, and that is what I already mentioned, people died 20 years earlier. And a lot of it is often from avoidable physical illnesses, and yet all this time later, as I've been going through my training and reading more and more reports, I focus a lot of my assignments on this because nothing's changed. People are still dying, and actually some recent evidence is showing that the gap is widening, not getting smaller. So there's lots of initiatives that have been run by the government, lots of reports that have been done. In 2021, NHS England identified serious mental illness as one of the 5 drivers for ill health in the most deprived 20% of the population. So they started something called the Core 20 plus 5 initiative. And interestingly, one of the other ones is about COPD. Now, our SMI population has very high rates of COPD. So, you know, even there, you've got all these things happening. Now, 2023, there's something called the National Mental Health Intelligence Network. Now, I'd never heard of them until I did the presentation. Now they do lots of data and they look at all of the facts that are going on, and they crunch it. And again, people with SMI are around 5 times more likely to die prematurely than those who didn't. So thinking, okay, so this has been going on for so long and people have been saying the same things and nothing is changing. So what can we do differently? And I think, you know, as a group, it's about, for me, we can do a bottom-up approach. The top-down approach isn't working. We can do this ourselves by changing our practice and by encouraging our colleagues to do the same. And I've done some training with my colleagues and made quite a bit of progress with this, actually. And it's interesting, it's exciting, and it's doable.
Absolutely. Hold your horses. I can see you going on there. Oh no. Let's just go back and look at a couple of things. So you mentioned the word iatrogenic, which some people might not be familiar with, and sort of explained it about sometimes the things that we do to help, such as prescribe certain types of medication, can actually cause problems. And so when you're saying iatrogenic, that's one of the things you mean. You also mentioned COPD, and it might be that a little while since people have done training and they might not be familiar with that. So
I apologise. So chronic obstructive pulmonary disease, so it is a range of conditions that affect your lungs and your breathing, and it is not curable, and it gets worse over time. There's no stopping it, but you can slow it down. But it leads to horrendous problems with breathing and movement and just getting about, and people slowly become more debilitated. It's a horrible illness.
And it kind of takes it back to one of the things you were talking about, because you mentioned a lot of the kind of things like, I mean, lifestyle choice is such an interesting one, isn't it? So how much choice do people have in terms of lifestyle? But smoking being something that links all this together again.
Yeah, and as I said, lifestyle choices, I was thinking exactly the same thing, because choices are forced upon us. So there's a thing of free will, isn't there? So how much free will do we have in the choices that we make? Well, they're very, you know, our free will is very much sort of decided by what options that we have.
And what our understanding is, who we're surrounded by. I mean, for me, things like smoking, if you don't grow up around people smoking, you probably don't smoke. Whereas if you grow up in an atmosphere where you need to self-soothe and other people are doing that and you don't have other options, it's something that comes up. It's something just that you're exposed to it more.
Yeah, and also smoking's very powerful. It can make you feel good in that moment. And you know, the things that make us feel good in the moment, unfortunately, tend to be bad for us, and smoking's one of them.
I was thinking twirls, but you know, I don't want to name any other products. But, so that's my go-to. So I think that's all about, you know, we must be really careful not to judge other people for trying to cope with unbearable situations when we all have our own version of it, depending on what
absolutely. I mean, I used to smoke, so that sort of you know, that description that I've just given is very much based on personal experience, and you know, and it is those things that make us feel good in the moment, don't good for us. But like, you know, eat, like you said about twirls, so the odd twirl is okay, but if you're going to be eating a lot of it, it's, you know, all the sugar and the fat and all those things. So I do it too, by the way. So I'm not some health freaks out here trying to send a message that we can all be perfect.
And nobody wants to see what people eat on a night shift, for goodness sake. It's never helped.
No, I used to work nights for quite a long time, so we don't talk about
I've seen some extraordinary meals on night shifts.
It doesn't count if it's at night on a night shift.
Good to know. Thank you for that health advice. Let's go on to the next slide and see what we've got. And Vanessa, did you want to say anything before we move on?
Yeah, I guess for me, because we've just talked about all the positive reasons why people smoke, I think there's something still though about dispelling this myth that it's a human right to smoke, and that people with serious mental illness want to smoke and don't want to stop smoking, because obviously the evidence is to the contrary, isn't it? That even people with serious mental illness want help to stop smoking. So I was just thinking that, because I do think that kind of myth still prevails a bit in mental health. So I think it's important, but I acknowledge that there are lots of factors, aren't there, that lead people to smoke, and certainly when people are in hospital as well, supporting people, you know, to stop smoking in premises where they're not allowed to smoke anymore, you know, without considering that smoking is sort of an addiction, and that we need to support people to stop. We can't assume that just because somebody comes into hospital and it's no smoking that they're going to stop smoking, given that it's an addiction. So yeah, I was just reflecting on that as you were talking.
Yeah, and smoking seems quite straightforward, but it's actually a lot more complex, isn't it? I mean, I stopped smoking because I wanted to start a family, and it was really hard.
Yeah.
Again, and I have a patient who stopped smoking years ago, and she's got COPD, and it's really affecting her, and it's awful. So, yeah, smoke, and that's the thing, isn't it, that we've already mentioned, that it makes you feel good in the moment, but the damage that it's done is so significant.
That's right. Yeah.
So yeah. Okay. So I'm going to mention something called the 5-factor approach. Now, I do listen to a podcast, called Psychiatry and Psychotherapy Podcast, and he's got a website as well. Now, this is sort of a very on topic, and all the episodes are full of research and evidence, and it has really influenced me, especially around this exercise and the diet and all those things. Because he really discussed everything in quite a lot of depth. And he mentions about the 5-factor approach, and they have an episode on it, number 207, as I've helpfully written here. So this is just about things that affect us physiologically and psychologically, and how they interact together. And if you have sleep, and you look at activity and nutrition and therapy and medication, and you cover those, that is your holistic mental health care right there. And because, you know, the sleep, activity and nutrition are so influential, which we'll talk about next, on just everything to do with our bodies. Therapy and medication, we're all used to those. It's definitely there. The focus is that I've always said, well, therapy was, as I've done my ACP, I did my prescribing training, and I got more interest in medication because I hadn't really had much I knew what I needed to know to be a mental health nurse, but I didn't know more than that, if that makes sense. But yeah, so these other three things have become my big things, and my patients in my clinic, they kind of got used to it, and it's actually, you know, been really positive for them as well. So should I go on to the next one?
Absolutely, yeah. That's what we're going to look at.
So that's just a starting point really for them. So we'll talk about sleep first, and I think everybody knows sleep is so important. I'm not going to talk about anything new, but the evidence is, you know, very sound. So everything relies on adequate sleep. So physical, cognitive, emotional functions. It helps to modulate our mood, physical well-being. Now, I've written here, it can be modified to fit our individual needs, and it almost sounds like a program, and wouldn't that be great? Because, you know, my sleep isn't great, and I'm not going to tell you about my sleep issues, but, you know, I do know it's not that easy. But some people need more sleep, some people need less sleep, and there are things that we can do to make sure or try and ensure that it meets our needs. But it's such an essential component of mental health. And if you think of some certain mental health illnesses, then sleep is part of the diagnostic criteria when we're diagnosing people. Sleep disturbance, sorry, let me correct myself there. Now, we've all heard that nighttime phone use and TV use is associated with the likelihood of not getting enough sleep. Using your phone at night, evidence has shown that you end up with a lower quality of sleep than people that don't. So even once you put your phone down, your sleep's not going to be as good. But good sleep protects us from severe problems with our health and well-being. And sleep-related accidents are major cause of injury and death. That's a bit alarming, but you know, it's true. So it's a fact. So your face is covered up my next slide. So half of it, but it's just poor sleep increases the risk of so many diseases, and they're written here on the slide. High blood pressure, diabetes, depression, cancer, heart attacks. Related to obesity in children and adults, reduces the quality of life. In older people, related to cognitive decline. They've actually said about night shift workers. And I think, oh, that's me. You know, I did work nights for years, but it's just so important. So this is the only slide on sleep. I've probably said things that everybody already knows, but it's something that with our patients we do need to be thinking about, because are they going out walking the streets at night? Are they pacing? Are they, you know, a lot of people will use their phones. What are they using for? And it's just having those conversations with people about good sleep hygiene, and have done some links to send you to some websites with. It is so variable on what's going to help. It all depends on the problems that are there and what people want.
I think what it does remind us is how we need to be on wards and in inpatient settings when on nights, because there's always one who just seems to put the radio on or talk at a completely normal volume, or when they go around just checking, it almost looks like a nighttime rage, you know, shining a light straight in someone's eyes, opening the door loudly, banging about. And I think because they're at work, they forget actually you're interrupting something which is hugely important for people's recovery. If people are not sleeping, they are not going to get well, you know, and it's so key. And we forget all the time, I think, on nights when we get used to working nights.
Yeah, definitely.
And I also think there's something about neurodiversity, isn't there? Because a lot of people who are neurodivergent have sleep reversal as well. And, you know, wards are very kind of high stimulating environments, aren't they? So sort of staying up all night when it's quiet is actually quite adaptive in lots of ways, but obviously not in terms of returning back, you know, to sort of life outside of a ward setting. So I think it's quite complex again, isn't it?
Yeah, definitely.
And we see, I think I've seen it a lot in people who are homeless as well, street homeless.
Yeah,
being awake when it's safer to be awake at night and then sleep during the day when there are people around. So you see that as well. And it's important to just bear it in mind, isn't it? What you're seeing is not necessarily people being challenging or difficult. It's actually that a way of coping, a way of surviving.
Yeah, and the brain learns to certain sleep patterns, so you have to retrain your brain, and it's not that easy.
Yeah.
You know, it's a really tricky thing to get right sometimes. All of these things are relevant for all of us as well.
Oh yeah, completely.
I wish we had a better name as well than sleep hygiene, which always sounds so creepy.
Yeah, I agree. I know it's a funny one.
Never cracked it.
I've always thought that. Yeah.
Different way of. I don't know sleep hygiene. Well, a lot of things to help you sleep. It doesn't trip off the tongue, but it doesn't creep people out. Okay.
It's a bit weird. Okay.
Thank you for that.
So next one, exercise. Everyone groans with this one, don't they? But when I was going through these slides before getting them ready for tonight, and now then, I'm going to go straight to the second box to start with. If I said to you right now, well, I know something that is going to improve your memory and brain function, protect against many chronic diseases, aid in weight management, it's going to lower your blood pressure, improve your heart health, the quality of your sleep, reduce anxiety and depression. If you've got cancer, it will help combat cancer-related fatigue, improve joint pain and stiffness, maintain muscle strength and balance, and increase your lifespan. You snap my hand off, you go, what is it? How much will it cost me? Do I have to pay monthly? Well, it's exercise and it's free. And yet, you know, we don't do it, I think. Well, lots of people don't. And our patients really struggle with exercise because it's about, we all know exercise is about routine. And incorporating into things and about being fun. And it goes back to what we were saying about smoking. The things that are bad for you give us immediate pleasure and immediate relief. The things that are good for you don't feel good when you start them. You get the benefits are delayed, they come later. But the thing with exercise, once you've been through that first bit, if you are really unfit, it does start to provide those benefits. So that's for, you know, all nurses or anyone working anywhere. Just, well, not even working, isn't it? Just literally every human being getting some exercise, it's going to help you. And for our patients, it can be missed, I think. Especially inpatients can be really difficult, or they're focused just on gym, or they'll focus, you know, just on one thing. So we'll go back to the other part of the slide now. I mean, it says there about reversing hippocampal volume loss. I mean, exercise, it makes your brain not just stop shrinking, but go, you know, get bigger again. That's, you know, that sounds like a win, doesn't it?
Yeah.
So just going down there, so it has positive effects on systemic inflammation. So that's just inflammation through your body that people can get. It makes you feel horrible and poorly. You don't always know you've got it. You just, you know, joints might ache. There's lots of technical kind of stuff there. Basically, it makes your cells work better. And then there's something here, it enhances insulin-like growth factor 1. I don't really know what that is either, but it's good for you. Now, brain-derived neurotrophic factor, so that's shortened to BDNF, and it's something that is made from exercise in your muscle cells, and it goes into your bloodstream, and it has antidepressant effects as it goes to the brain, and that is a free thing that will help, help with low mood. So that exercise, so that's why weight training is so good. Sorry if I'm stumbling my words a little bit here. That's why weight training is good, because it builds those muscles and it gets that BDNF being produced. And it all sounds very technical, because it is. Our bodies are these amazing machines, and they do all of this stuff. And there are lots of technical words. And exercise, so exercise that gets you out of breath and exercise that helps to develop your muscles is going to benefit you a lot. And you don't need to do much. It's finding what your own thing is. It's starting slowly, and getting your patients just to do little things. So anything is better than nothing, and any improvement, a little improvement, is better than no improvement at all. And like I say at the bottom, don't go all out. It's not sustainable. I did that. So I was really fit before COVID, went back 3 years later, thought I can do this. My body will just snap straight back. I think after 2 weeks, I had to take a month off. Yeah. Oh, it was brutal. So it's just about being sensible, isn't it? But it's so important, and that's why there's so many health campaigns. But if we can get our patients doing it, so if you work in the community, you could meet your patient and go for a walk rather than just going to their home all the time. If patients are on the ward, it's like, what exercise programs are there? Because I think there's better governance over that, about what should be happening on the wards. So it's just being creative and doing it for yourself.
I think one of the things that I found really helpful, and they got absolutely exploded over COVID lockdown, was those indoor walking things. So loads of freebie stuff on YouTube, and I often take off their music and put my music over the top of it. and just have like that, even 15 minutes, 10 minutes walking, your brain's somewhere else altogether. And it's something that, more than one person can join in. You can actually do it with friends over Zoom, whatever it is you're doing. Even on a ward, it could be really useful. And it's a private, cheap way of doing something, and having that encouragement. Because I think sometimes when you're by yourself, it's really hard, particularly if you're struggling with weight or with anxiety around being outside and things like that. You can start easier. It doesn't have to be buy a load of expensive gym kit, sign up to a gym you're too worried about using. And the other thing is, there are ways of getting involved with social prescribing. So if you're a service user and you want to have access to things, actually start asking. And if you're a practitioner, start making connections to your social prescribing networks, because you've got green gyms. It doesn't have to be exercise like you were saying, running around and stuff. If you do gardening, you're lifting weights, you're moving, and that stuff's just as important. So there's lots of different ways that you can get access to stuff that maybe feels too expensive at the moment.
Yeah, because it is expensive, isn't it, if you're joining a gym? And I do better when I go to classes, because my self-motivation is really poor to do things. So it is about getting people out, going for walks, and just try and find something people enjoy, what their interests are.
Yeah, and also different age groups are going to want to do different things for sure. And you've got the different, sometimes different genders have different interests. And I hadn't seen the walking football and walking rugby before, but they're actually good fun. So if you're working with, because I found it really easy to get groups up and started on women's wards and even mixed wards. But working in male only spaces can sometimes be a bit of a challenge if you're trying to get group activities going, get a bit of enthusiasm. Not as easy, I would say. So it's really important to make sure that we don't, obviously everyone likes different things, but just to be aware that there are some things that can be an easier sell. So tailor your activity to your population, I would say, as well.
In the community, there tend to be a lot of groups. So in Nottinghamshire, they waterways do paddleboarding for people with mental health difficulties. Mine do Nordic walking. There's different things. It's just knowing that they're there and just being curious about what's available.
Yeah, brilliant.
Okay, so So I've got two different perspectives here. So we've got mental health illnesses with nutritional consequences. So yeah, we've gone on to nutrition now. So eating disorders, that's an obvious one, isn't it? We all know that one. Dementia in older people, so you've got an increased risk of malnutrition, you've got frailty and falls. Food refusal, you can get that in depression or psychosis. Abdominal pain and anxiety can lead to people not wanting to eat or just only eating certain things. In learning disabilities, there are different syndromes that will give them increased risk of some nutritional difficulties. You've got Prader-Willi written here. Now, we know there is a higher incidence of obesity in people with serious mental illness. That unfortunately is a fact. Medications can cause increased appetite. They can also reduce appetite, cause nausea. And we know medications can have a lot of metabolic consequences that even if people eat the same amount of food, they will put on weight. That's a big thing now, isn't it? With especially some of the antipsychotics and some of the antidepressants. We've just been talking about inpatients. When they're in, they can usually less active, can lead to weight gain. But also perhaps they're eating better. But I think, yeah, it's a lot more complex. All of these are more complex, and I'm just trying to keep this simple here, really. We also have physical health illnesses with nutritional consequences, and there's a big list here. So I'm not going to read it out, but it's just about being curious about what your patients have got and what that illness may mean for them nutritionally. It might mean that they can't absorb things properly, or they might have imbalances like in diabetes. So it's just about being curious about what that actually means for their nutrition. Do you want me to talk about this one, or should the next one is also about nutrition?
We'll carry on with nutrition, and we'll come back, because there's lots to be said about hospital nutrition. Everyone's just like
an awful lot. So mental health benefits of the right diet. So same as exercise affects our cognitive and emotional health. Now, I don't know if I was really surprised when I found this out. The brain uses 20% of your calorie intake. So like, that's a lot, isn't it? And like, it's not 20% of our size. So if you think, the way I then thought about that was, well, if it's using 20% of the calories, then 20% of all this stuff that I'm eating is getting my brain working. So no wonder sometimes I feel pretty terrible, because sometimes the food I eat is pretty terrible. Well, it actually tastes really good, but when it comes to nutritional thing, it's not great. So, you know, the right diet, now this is can leave significant improvement in depressive symptoms. Actually, the right diet can lead to depression going in some people can be more effective than antidepressants. I think the rate is about 30%, but the research is very sound, and there's quite a lot of it as well. And that's pretty major stuff, isn't it? That you could actually change your diet, and then you don't need to go on these antidepressants with all their range of side effects. And then maintain that diet reduces the risk of future depressive episodes. And going back, so this, have you ever been hungry? Going back to the brain uses 20%. So you think about it, and it's really, I think, a great cause and effect example that you're feeling all, I don't think it's just me, because it is a thing, isn't it? Hungry. And then you eat something and you feel better. And that just shows that direct link between what you eat and how you feel. You've got vitamin deficiencies that lead to, you know, can be mistaken for depression. I pick that up a lot in my outpatient clinic, actually. You know, people will come and I just think, right, you know, we need to get bloods for these things, and they come back and might have low vitamin D or folate, low iron.
Low iron is a big one, I think.
Yeah, massive one. Now I
across
had
it
low
all the time,
D, and it was horrible. It's really painful, low vitamin D. You know, I thought, blimey, I thought, you're over 50, Linda, but blimey, you're just turning into this hardly move. It's awful. So don't underestimate, and you know, the power of some of these nutrients and how they make us feel. Lisa mentioned as well, what can we do? I had written, get rid of processed food, and I thought that's a ridiculous thing to say, because shredded wheat, I have it every morning. It's really healthy. I have it because I just like to eat the same thing every morning, not because I'm a health freak. But that's processed and it's just wheat. So when we say processed food, you're looking at, there's that thing isn't about the ultra processed food. So you just think, is it high in fat and salt and all those things? We know what's bad for us.
Yeah.
And I'm talking about us as a whole, because this isn't just our patients. So this
Yeah, no, absolutely not.
Exactly.
And when it comes, yeah, so that's why it's the us thing, because this isn't, for me, with all of this, it isn't a them and us. This isn't, we need to do this for our patients. We need to do this for us and them.
Yeah.
So it's an everybody thing.
Mm.
So eating healthy foods and making small changes. So I'm not sitting here saying, oh, here's the healthy food pyramid, always choose things from them. And I wouldn't actually sit with a patient and share that. Some people would, and you might find it helpful. And so might the patient, because it is about knowing your patient. But it's also just about making small changes that are going to improve our diet. That when our brain's using those nutrients, it's got good ones. So we're not going without and being hangry, and we're not getting that food coma.
I think you've touched on a lot of really important things there. So I think one of the first things that stands out is that you can be full but not nutritiously full.
Yeah.
So some people do have enough to eat, but it's nutritionally empty, really. And that's something to be concerned about, because that's going to impact their well-being. But also, we're not necessarily great at health promotion in mental health. We spend a lot of time talking about the brain and the mind and prioritizing it almost over the body, and thinking about risk and the things that we do well, we do pretty well. But I think there's issues around sometimes how we talk about healthy eating. Either comes exactly as you said, people get out that kind of like plate thing and start pointing out, and people are like, I'm aware that I shouldn't just eat chocolate, thanks. However, that's the only thing I've ever seen you eat. So it's really interesting how we manage our own feelings around health promotion, our own health and well-being, because there's something in nursing as well about putting yourself, suffering a little bit makes you a better nurse. Someone who misses lunch and works through lunch, and so we need to look at those sort of behaviors in ourselves a little bit, so that we can then be confident to talk to other people about how they can have better diet. And also the embarrassment. I mean, I'm sure every nurse has had this, when whatever comes up from like the cook kill kitchen, you're like, what's that awful smell? And someone says, oh, lunch is here. And you're like, oh God, oh no. You start talking about healthy eating and you're like, what are we doing?
Our hospitals don't have access to anything except a machine with some grotty old sandwiches or, sweets and crisps. And then, we're talking about low vitamin D, but people who are on permanent nights, will, have low vitamin D potentially. And then, as we say, poor access to, food during the night, or food that is going to help to keep you awake through the night. I certainly remember doing that. You'll do anything when it gets to about 3 o'clock in the morning to stay awake, and that's generally caffeine and sugar, isn't it? Or takeaway or something. So it's
I think that idea again about rewarding yourself with food is something that people learn in childhood very young, particularly if they don't have other types of emotional support.
Yeah, totally agree.
And you can absolutely understand why people do it. Exactly as Linda was saying, it's that immediate thing. But also we when someone's starved of other types of sort of love and comfort, it's easy to get mixed up between what is actually what you would want for somebody else and wanting it for yourself. Because often we're much better at understanding what other people should have or do than thinking about it for ourselves.
Definitely. And also the other angle is that food can be really social, like bringing some biscuits in our or something.
And cultural.
A social, nice thing to do, isn't it, as well?
Yeah.
And also we're programmed genetically to like high fat food, because all that time ago, that was calorie dense food was what was going to keep us going for longer. So your fruit and veg that we like to talk about now, they were part of a diet, but they weren't back in those days, and when we sort of developed genetically, that wasn't there. So we have got this programmed into us to like those nice foods with high fat content. So we're kind of having to go against what our body is telling us we need, but because of how society is now, we don't need all those things. you know, we have our calories, but our bodies just sort of they haven't caught, evolutionary wise, if you like, haven't caught up with that. Whether it will, you know, who knows? But and I think we also have to think about people in poverty and how easy it is to access food, because some of these foods that are bad for us are cheaper
and closer.
So it is hard to make healthy choices sometimes. You know, a thing of, so Morrison's do a thing of grapes, and I'll treat myself to that because they're like the really nice ones. It's £3. I'm like, £3. It's a lot
But
of
the
money.
price of food has really gone up.
Fruit's really expensive, isn't it now?
So it's great with all this advice, but it's about how do people afford it? And you know, when people are busy as well, it's really not that easy to go, oh. So if we're struggling with that, our patients are certainly going to be struggling with that. And just having the fridge and looking at sell-by dates and having a freezer and all the things that you need to be able to do all of this isn't necessarily that straightforward. We make it sound it. So that's why any small changes that people can make, I think, are what we aim for, rather than getting out that food pyramid and going, this is what you should be doing.
Because it needs to be culturally specific as well. A lot of the kind of public health information is kind of very white Western, and that's not the food that some people eat. So bear in mind, I don't think we're really great at this in services, but the voluntary sector, some parts of it are really knocking it out of the park on this. So the Bridge at Southwark, which is a women's centre, buys food in bulk, and then people buy it off them. So they're operating as a middle person, a middleman type thing, and actually helping people to get cheaper food. Cooking lessons, group cooking lessons. So you've got isolation being broken down, sharing, people cooking for each other so that people can get a rest, you know, actually making those social connections so people don't have to survive just by themselves all the time. And, you know, because I think, Sally, as Linda's saying, it's tiring to cook sometimes, and when it's just you, and if you feel low in mood, it might be hard to motivate yourself, particularly to eat healthily. Whereas if you're doing something for other people, it feels slightly different. So there are things that we can do, and they're not high tech and they're not beyond us, but it's about thinking that actually this is part of our job too.
I agree.
Linda's done a brilliant job bringing this up into practice. We're getting to our last slides now, so let's press on.
So the next one is just about hydration. You can't do nutrition without saying about hydration. You know, dehydration is horrible. In some of our medications cause it, don't they? Lithium is a prime one, but increased thirst, dry mouth, dry lips and skin. I'm not going to go through the list. Dehydration is really bad for you, and you know, your blood then gets thick and sticky. It's not going to be able to get around your body. You're more likely to get infections, and you know, a urinary tract infection, they're horrible. Whereas if you can keep hydrated, you know, even just getting your body temperatures better regulated, so people are healthier because your blood can get around because it's not thick and sticky. You know, there's another long list here. Everything's better: muscle function, organs, sleep quality, your cognition, your mood. Just all your cells are getting the nutrients that they need, as well as they can do based on what we're eating, really. So I think it's just really important. And obviously, you know, being dehydrated is dangerous, but so is being overhydrated. Not drinking too much, and people get, you know, those 5 litre a day thing that was pushed by the water companies those years ago, and that's not actually what you need. If you're thirsty, you need to have a drink. There is fluid in food depending on what you eat. It's listening to your body, and thinking about what you are actually drinking, and is it going to dehydrate you or not. A good test is your wee. Is it pale yellow? You know, if it's dark, you're dehydrated. If it's like water, you're probably too hydrated, or you've got something that's making you pass more water out. You know, you've drunk something. Coffee can be a bit like that. It's for me anyway. But yes, it's just being aware of that is very important, isn't it? And I think a lot of our patients forget to drink, especially if they're really unwell or they're drinking the wrong things.
And there's loads of things you can do with that. I remember when I was a student nurse, one of my mentors at the time said, when you're thirsty, just assume everyone else is. And just when you go out, off to make a drink, if you're ever going to sit one-to-one with someone, off to make a drink. You know, if you know that it's lunchtime or breakfast time or something like that, get people a drink. you know, it's part of showing somebody that you care about them. But it's also really important to just stop it, because they were like, you do not want UTIs happening. And I said my first UTI, I was like, I don't want UTIs happening. And I really am motivated. But it's part of like showing compassion for people, isn't it? It's, but there are some people who worry about stuff like that. Oh, it makes me look meaner on it. Makes you look like a person who cares about other people's well-being. That's what it makes you look like.
Yeah. Be caring and kind. And I think that's, you know, at the base of what we all try and do, isn't it?
Yeah.
So my
last one.
The last thing I want to talk about is something called a MUST form. Now, some people may or may not know it. So it is the Malnutrition Universal Screening Tool. There is a link if you something that you want to use. If you're concerned about someone's nutrition, then fill it in. It will tell you. It's got a good scoring thing on it. So it's good for people that are underweight and also people that are overweight. I've got the nice guidelines here of what is classed as underweight or as malnourished, if you like, at the underweight scale. It's because frailty and malnutrition often coexist. Obesity, so I can't see what that is now because it's hidden by your face, Nicky. So obesity and poor diet, that's it. Linked with type 2 diabetes. Lots of different things are listed in the slide, but 64% of adults in England are overweight or obese. So use the MUST form for them. It is really helpful and can help to track things as well over time. I also want to mention something called refeeding syndrome. So if you have someone that's really underweight, refeeding syndrome is a risk, and it is very rare, but it can be fatal very quickly. So it says here, so if someone's had little or no food for 5 days, they've got a low body weight. So don't think BMI, just think that they're really skinny. The lower, the lower the body weight or the BMI, the higher the risk, and the longer with that. But that goes without saying. So for the technical people, refeeding syndrome is where, so the body's been using ketosis. So basically it's using your fat and your muscles for energy. It's consuming, your body is consuming itself to keep itself going. And then when you start eating, it switches to using the sugars from your food, glucose metabolism, and that causes a change in your electrolyte levels. It can be dangerous. So if someone is like that and you suddenly think, wow, they look really poorly, they need to get to hospital. I'm not going to go into the symptoms because they will look ill and they need treatment very quickly. So they're just sort of, as you know, practitioners, things that are really important, I think. And my very last slide has just got all the links and that on it, so we don't need to go on to that. That can be included.
We'll put that out. So for anybody who wants access to these slides, we'll retweet them. They'll be on the MHTV link. Let's just, because we've whizzed through this, and I hope everyone was on board with us doing something slightly different this week. But I think it's really useful to, like, first of all, celebrate like our colleagues becoming even more skilled and bringing this stuff to the fore, but also looking at how we can keep improving practice. So let's go to Vanessa, and then we'll go on to Linda to see if there's anything they particularly want to emphasize from what we've been talking about. Vanessa?
I think for me it's just the importance of looking at the whole person, isn't it, and being holistic and thinking about the interaction between physical health and mental health, and as we often say, kind of moving away from the medical model sometimes and really looking at the way in mental health that some of these factors impact on a person's mental health, and the way mental health impacts on some of these factors also. So for me, it's just been a useful discussion, and I think it's ongoing, isn't it, in mental health, the importance, certainly, where I work, we've got a physical health team, but I think there's still loads of work to do around, our mental health nurses seeing this as part of their regular practice, and that's culture, isn't it? It takes years to change, but I think conversations like this help, and they're important, aren't they? And I think finally, I just think that it's been really important, Linda, that you've emphasised that this is about us as well. So this affects all of us, doesn't it? It's not just about a population of people we look after, we're all the same. So thanks. It's been an interesting topic. It's been quite nice to have the slides as well, hasn't it, Nicky, for a change? Just to bring a different dimension to the conversation.
Is there anything you particularly wanted to highlight, Linda, before we head out?
Just briefly, that if we can do these things, then we're going to help our patients. You know, doing it for ourselves, that's our choice, isn't it? But doing it for our patients, they have, you know, they're dying too soon, and it's a really long time too soon. And if we can help them with these three things, then even if it's just a little bit, we're going to add time to their lives, and we're going to have add healthy time to their lives. This isn't just about, you know, adding a bit here and there, but will make a real difference. And it's about starting a bottom-up approach, you know, really getting the people that are working with the patients to see this as important, because we will add years and healthy years of life to our patients, and they deserve it, don't they? We're doing this job because our patients deserve the best care. This is part of that best care. It hasn't traditionally been seen like that, and I didn't see it like that, so I'm not sat preaching to you going, I've been doing this all the time, but I've seen this, actually I need to be doing this, and we can really make a difference.
Thank you. I think that's a really good place for us to end tonight. So I hope you found it all interesting, and we'll be seeing you again soon. Thanks very much, everybody. Take care. Good night.
Bye.
Good night.
Bye.